Explain what the difference is between the spinal fusion and the artificial disc replacement.
Sure. Um, I'd like to step back just a little bit. Most of us know people that have an artificial hip or an artificial knee, maybe our grandmothers or aunts or uncles. Um, However, what most people don't know is that before there were artificial hips and artificial knees, people that suffered severe pain underwent operation called knee fusions or hip fusions. Now, they were good operations because they relieved pain, but the problem is they would like weld the knee together or weld the hip, and they limited motion. So, in the 1960s and 70s, and out throughout the 80s, the total hip replacement and total knee replacement evolved. And now, here we are in 2008, these operations are very commonplace. I have an example of an artificial hip replacement, and this is made of a metal alloy. This one happens to have a ceramic head, and then the cup is made of metal with a polyethylene liner, and then this helps the hip to move.
Unlike before when you were showing me the older one where it would just be fused in place and there would be restriction on the mobility.
Correct. Then the hip couldn't move. You'd have to use your spine and your knee to help move. The other model I have is this is a knee replacement. And this is the part that goes on the femur, which is the thigh bone, and this is the part that goes on the tibia or the shin bone.
And these are the actual parts that goes inside of a person's body.
Yes, that's correct. And this allows, I'll turn this from the side, if a person was standing straight, it would look like this, and as they bent their knee and brought their knee up towards their buttock, or it would slide this way, or if they sat down, the thigh would bend. So this was an evolution of technology from going to welding or fusing bones together, such as in the knee or the hip, to having motion, artificial joint replacements.
And a good example of that, too, is what you were showing me in the back here, how in the past they used to fuse things together. This I found very interesting.
Yes. This is a model that I use in my office of a spinal fusion, a low back spinal fusion. We call this the lumbar spine or a lumbar spinal fusion. And the classic fusion is performed through an incision on the back. It has screws and rods that are made of titanium. And also there's struts, the discs are taken out, and struts of bone or other types of material are placed between the vertebrae. And this is an operation that is the classic operation for painful discs. It works. However, it does have some negative aspects to it. First of all, the patient will lose motion. You can see the upper part of this spine moves. And that's supposed to simulate normal motion. Well, the bottom part that's fused together is pretty much welded. That doesn't move. So if you had this operation, it could take away a lot of your pain. However, it also ends up restricting your motion. And then there's other issues or nuances about spinal fusions. Patients that are smokers may not heal as well. Other issues regarding when a fusion is done, the joint next to it, and in this case would be the disc next to it, has to take up more stress. Well, the disc or joint next to the fusion can go on to accelerated deterioration, and then the patient would need another fusion.
And you also have, while you're talking, I'm wondering if you could hold up the way that you're doing it now, too, so we can get a visual of that, too.
The newer technology is that of an artificial disc replacement. And if you kind of look at these together, the bottom of the artificial disc replacement looks very similar to the bottom of the artificial knee replacement.
Yeah, I see that.
And this is implanted through an incision, a small incision in the abdomen. I work with a team of surgeons to do this, either Dr. Michael Pell or Dr. Timothy Rasmussen, both excellent surgeons, and we do these surgeries together. And we'll take the disc, the entire disc out from the front, and then replace it with this disc made of a metal alloy and polyethylene, high density polyethylene.
And once again, you are actually showing us the pieces that actually go right inside the body.
Yes, yes.
I just find this so incredible.
And as you can see, it moves. This would be bending forward, bending backward, bending to the right and left, and a bit of rotary motion. Now, one may say, well, geez, that's not much motion, but there are 5 discs in the lumbar spine, and if each one moves this much, well, it's like a fishing rod or a bicycle chain.
Exactly. Unlike when you're fusing them together, the motion is really restricted.
Yes. The advantage of this operation is, number one, it preserves motion. The other issue is that when we put an artificial disc in, the discs next to the replacement do not take up increased stress. So statistically, people should not be coming back for additional surgeries at the levels next to the artificial disc replacement compared to the fusion.
That is pretty incredible. This is wonderful that we have such great advancements in the medical field. This is so helpful.
It is. For smokers in particular, we do have the challenge of the patient that is a smoker statistically has more of a chance of not healing the fusion. There's numerous reasons why, but those are the basic numbers compared to a smoker, non-smoker. However, smokers and non-smokers heal the same with the disc replacement. So that other variable of smoking is taken out of the equation when a patient has a disc replacement. The hospitalization time with an artificial disc is usually 2 or 3 days. With a spinal fusion, can be 4, 7 to 10 days, depending on the size of the operation.
So if somebody watching today is in a lot of pain and has maybe even had a spinal fusion in the past, are they able to come to you to talk about doing something different, or is it too late for them?
At the levels that are, it depends on the type of fusion that they've had. However, there are patients that have fusions that, as we discussed earlier, will go on and start to have pain out of the next disc. Those patients would be a candidate for an artificial disc replacement at the level next to the fusion.
So even if they've had a fusion and they're having pain today, they can come and talk with you to see what possibilities exist for them.
Yes. First, I wanted to show you a model. I use this with my patients. This is a model of a cervical fusion. So similar to our patient George, the classic operation would be to make an incision on the front of the neck and then take the discs out and put a device to fuse the vertebra together with a plate and screws. And that's an operation that works and does take away pain. However, like the lumbar operation, we have to be concerned, is it going to heal or not? There's an added risk for a smoker. And then we have the other issues regarding the potential for the discs above and below to go on to deterioration and require another surgery. So those are big challenges. As we look at a patient and treating them medically, we just want to make them better the first time. The artificial disc replacement is actually, as we would say, a mini-me of the lumbar. And if you look at it, and this one I can take apart because it's magnetized, it's actually about the size of my thumbnail. Wow. And this is an actual prosthesis that we use in the operating room. And once again, it's made of metal and polyethylene, and it allows the neck to move. So if from the side, you can move up and down, okay? And you can turn and also lateral flexion. So this is a very large step in the evolution of treatment of injured discs. And I believe that this will be with us for a long time.